Okay, so after looking into the physical examination, one important aspect about asthma is that we need to realize that there's not all that wheezes is bronchial asthma. We talked about wheezes being a very important point in history, and it's also probably the most important physical examination finding. But asthma isn't the only disease that can give you wheezing during physical examination. And this has been recognized since 1930, or maybe even earlier, by a famous American ENT surgeon. And as you can imagine, there's a lot of other pathologies that involve the upper airways that can, sound similar in many ways to asthma. So when do you think about these other diseases or entities that might mimic asthma? So for example, if there's no prior diagnosis of asthma, then of course it could be the first presentation of asthma, but you always have to think, well, maybe it's something else. Also, difficult to treat asthma is a very famous entity. If a patient is being on complying with treatment and they're still having asthma episodes, or their asthma is really severe and they're having a lot of exacerbations and being admitted frequently, or they having some complications, then it's also another entity that you might think, okay, maybe it's asthma and something else, or it's maybe like just something else, not just asthma. Localized wheezing and in asthma, as we talked about in physical exam, it's usually generalized, usually in the lower airways. But if you have a localized wheezing in one particular part of the lung exam, and if you predominantly hear it in the upper airway, then you maybe think about other pathologies as well. Hemoptysis is not common with asthma at all, though a patient with respiratory symptoms and hemoptysis, maybe it's a clue that there's something else going on. Elderly, I'm always skeptical when I hear that a patient is developing asthma for the first time when they're old. But of course, adult onset asthma is an entity which is well known and it happens. But you need to think about other diseases. For example, we talked about that. We'll talk about cardiac asthma as one of the differential diagnoses. So it's maybe more common in people who are especially like ischemic heart failure. Maybe more common in all patients with atherosclerotic risk factors. If there's clinical features that suggest other diagnoses from history or exam, or other imaging or investigation that also suggest other diagnoses, then you need to kind of think about what else could it be. So, what are the other differential diagnoses of asthma or wheezing on examination that you have to think about? Of course, the list is long, but we're gonna talk about maybe the most important ones. COPD is really important. It's other chronic obstructive disease that's also relatively common, and it might exist with asthma, so patient might have element of both. But we always talk about asthma being reversible and COPD being irreversible to some extent or to most extent. And hyperinflation in patient with COPD, like patient with emphysema, usually happens even without acute exacerbations. So at baseline, because it's a chronic disease, there might be like feature of hyperinflation on exam and also in imaging in COPD compared to asthma exacerbation, when they usually have hyperinflation only during acute exacerbation or unless they are really poorly controlled. Heart failure is very important, very common disease, and also very important differential. Some people call it cardiac asthma, and that's probably because of the constriction of the airways because of the pulmonary edema that may happen with heart failure. So you need to think about if the patient is having risk factors for heart failure, ischemic or non-ischemic, and also look for other features in exam that suggest heart failure, like increased JVB, third heart sounds, pulses, paradoxus, low serum edema, basal crepitations, hepatomegaly, all the other features of heart failure. You have to do a good physical examination to sort that out, and maybe consider ordering imaging and maybe even echocardiography to look for features of or cause of heart failure rather than asthma. Other causes of airway obstruction, that's really important, especially upper airway obstruction, like foreign body, tumors of the upper airways like squamous cell carcinoma, adenoid cyst carcinoma, mucus plugs, especially in patients with chronic lung disease like cystic fibrosis or in the ICU, tracheal stenosis, laryngeal, tracheomalacia, vascular rings, or drug reaction and anaphylaxis all can cause obstruction of airways. Usually the history could be straightforward and helping in making the diagnosis, but it's not always clear. Imaging in these situations might also point towards finding like a mass or something in the X-ray. But keep that in mind. Other chronic problems in the upper airways can mimic asthma. Bronchiectasis, another chronic obstructive disease, also relative, is not uncommon. It has many underlying causes. Patient might have features similar to COPD or obstructive disease. Patient might have increased expectoration even at baseline, large sputum production, history of recurrent pneumonias or pneumonitis. Might have hemoptysis because of the parenchymal damage that happened in the lung, and inspiratory crackles rather than expiratory wheeze. Imaging might be very helpful to kind of suggest the features of bronchiectasis, but you also need to kind of think about the underlying cause of bronchiectasis if it coexists with asthma. Aspiration, especially aspiration of acid material like in severe GERD. This is very common coexisting disease with asthma. We're not really 100% sure if it's a cause of asthma, but it's definitely well known to be a cause of making asthma bad. So ask a patient about any GI symptoms or reflex symptoms, heartburn, acid sensation in the throat. Sometimes symptoms can be at night also, that which might be difficult to distinguish from asthma. But if you're suspecting it and if there's no red flags, maybe you consider treating the patient for GERD and see if that helps treating or controlling the asthma in these patients. Another important vocal cord disease is a paradoxical vocal fold motion disorder. Used to be called vocal cord dysfunction. And it might be associated with throat tightness, dysphonia, or changing the quality of voice. Stridor rather than wheezing is also more evident. Diagnosis is usually made by laryngoscopy, and they need some sort of evaluation by ENT and also speech therapy. But there's some feature that can distinguish this entity from bronchial asthma. Postnasal drip, also think about it in patients with sinusitis because of the continuous drainage at the back of the throat. That might irritate the airways, causing worsening of symptoms of asthma. And patient might have symptoms of sinusitis, tickling sensation in the throat, and throat clearing like this all the time. It could be a clue. So you need to kind of tackle the underlying sinusitis, and that can help controlling the asthma. Patient with vasculitis, like eosinophilic granulomatosis with polyangiitis, or vaginal granulomatosis as it just used to be called. Pruritus nodosa also. These are probably the most important ones among others, but they're usually rare. They usually happen in younger patients, with also kind of feature of asthma as well. But this could be a clue to the presence of vasculitis. Look for other organ involvement, like for example, CNS involvement, especially like mononeuropathy or mononeuritis multiplex, cardiac involvement with myositis or pericarditis or even the carditis, skin and musculoskeletal involvement, GI involvement. Multi-system involvement also kind of suggests vasculitis rather than just bronchial asthma. And also the labs, like ANA, ESR, CRP also being high or abnormal can suggest underlying vasculitis as the cause of wheezing or underlying lung disease. Pulmonary embolism, not very commonly associated with wheezes, but it might happen in 10%, maybe in patients with PE, they might have wheezes, and it could be the trigger of asthma exacerbation. So keep a broad differential if the patient is presenting with some pleuritic chest pain or with some risk factors for thromboembolism. Maybe consider getting a CTPA or CT with pulmonary angiography to look for underlying pulmonary embolism. Allergic bronchopulmonary aspergillosis is also a very important entity that usually exclusively happen in patients with asthma or cystic fibrosis. There might be some coughing with brown black mucus plug that could be a clue in some patients, and hemoptysis again also can be a clue. Systemic symptoms like fever, lethargy, or weakness, and of course imaging and lab findings can be also characteristic. There's some criteria that you can keep in mind in this patient. They might have like a positive skin test for aspergillus, which is type 1 hypersensitive reaction. They might have a eosinophilia. We'll talk about that in the next slide. Serum IgG, again, Aspergillus fumigatus, again, also can be a feature. They might have like a transient pulmonary opacities, like they call it fleeting shadows. Can be also a clue, or central or peripheral bronchiectasis with normal tapering of distal bronchi. That also could be a feature of ABBA. Recent or recurrent or relapsing polychondritis with airway involvement, also a rare disease. Inflammatory disease, underlying diagnosis uncertain, but it's usually could be associated with autoimmune disease. There may be like nasal involvement, articular involvement of joints, and ocular symptoms as well. That could be a clue. And the relapsing or recurrent symptom or nature of symptoms could be a clue as well. Again, it's not very common, but something to keep in mind. Some interstitial lung disease like hypersensitivity pneumonitis, like farmer's lung or bird fancier's lung, eosinophilic pneumonia also. And these are also very kind of like, for example, hypersensitive pneumonitis is kind of the occupational history is important, and the fact that maybe they get worse during exposure and they feel better without exposure. Eosinophilic pneumonia, we'll talk about that in the next slide really briefly, can also be seen in ground glass opacities and high resolution CT scan. Pulmonary function test can also help in these interstitial lung diseases. Featuring like interstitial or fibrotic pattern compared to obstructive pattern of asthma. And then of course BAL during bronchoscopy, bronchoalveolar lavage can also be a clue, and the finding of eosinophilia can be helpful. Sarcoidosis as also part of the interstitial lung disease. There's endobronchial involvement, can mimic asthma. It's more common with Black and North European patients. Look for other symptoms that might suggest sarcoidosis. Also, patient might have some history of autoimmune disease, and if there's any clinical suspicion, consider biopsying the organ involved for looking for the definitive diagnosis and then considering granulomas associated with sarcoidosis. Parasitic infections, if there's history of travel, or there's when patient is coming from endemic area, there's different parasitic infections that can give you symptoms similar to asthma, so you have to keep that in mind. And acute chest syndrome in patient with sickle cell disease also sometimes might give you wheezes and acute respiratory symptoms mimicking asthma. Neoplastic disease like carcinoid syndrome. In this patient, 25% might have some wheezes, but there might be other features to suggest a diagnosis like flushing, diarrhea, right-sided cardiac valvular disease might happen with this patient. Patient with lymphangitic carcinomatosis, involvement of the lymphatic of the lung from any cancer, specifically or more commonly with breast cancer, lung cancer, GI cancer, prostate cancer, thyroid cancer, all can give you a lymphangitic carcinomatosis picture. Imaging usually helpful in these situations. You might see something like septal thickening that you don't usually see with asthma. Factitious asthma, again, a diagnosis of exclusion. Typically, classically, prescribing patient, young, relatively young, maybe women more common than men. History of psychiatric illness or history of hospitalization or hospital employment, or knowing a family member who had who work in the medical field. The attacks or the questionable asthma-like attacks are associated with more with stridor rather than wheezes, as in the upper airway diseases we talked about before. The airway sounds are best heard over the larynx or in the upper airways. Look for social stressors that might be precipitating the quote-unquote attacks. But usually the physiologic changes are absent, like there is normal alveolar AA gradient, or no hypoxia per se. There may be normal imaging and normal pulmonary function test. This all could be a clue that needs a diagnosis, that the diagnosis is factitious rather than true bronchial asthma. Here, I just want to emphasize that even in the presence of eosinophilia, it still could be something else other than bronchial asthma. And we talked about most of these diseases before. We talked about allergic bronchopulmonary aspergillosis, Loeffler syndrome, which is basically respiratory symptoms with transient infiltrated imaging and increased serum eosinophils, can happen from different causes, most commonly parasitic infections. We talked about that briefly. So look for history of travel or patient coming from endemic areas. Drug history is very important. Look into the medication that the patient has been prescribed recently or increased in the dose recently, including many antibiotics, anti-inflammatory, anticonvulsants, and some immune modulators. The list is really long. We talked about vasculitis. There's another entity called hypereosinophilic syndrome, or HES, basically eosinophilia, and an organ damage that's caused by the eosinophilia. So not just presence of eosinophilia, but the actual tissue damage, the organ damage is caused by the deeply involved in the within eosinophilia and increased eosinophils. And then tropical pulmonary eosinophilia, also in appropriate history or travel history or patient from endemic areas. This is caused by lymphatic filariasis or some nematodes like Wuchereria bancrofti. I like to call it like elephantiasis of the lungs. It can also mimic asthma, and there's eosinophilia. So just keep in mind that it might help kind of narrow the differential a little bit compared to the other causes of that might mimic asthma and wheezes, like heart failure, for example, is not known to be associated with eosinophilia, but this could be, and you need to think about them in appropriate setting. Excellent. So we're done. So basically, we talked about what is bronchial asthma. We talked about the basic epidemiology of asthma very briefly. We talked about the symptoms of asthma, the allergens that commonly involved. We talked about the triggers of the exacerbations, aspirin-sensitive asthma. We touched about occupational asthma, exercise-induced asthma, obesity, and asthma, and physical examination in patient with asthma. And we talked about differential diagnosis and other causes of wheezes and asthma-like symptoms, and the famous phrase that not all that wheezes is asthma. If you have any questions, don't hesitate to make a comment in the video or send me an email. If you have any remark or comment or anything that you would like us to talk about in the future. So thank you very much, and I hope that it was helpful. Take care.